Hi, everyone. Welcome to Misconceptions. I am thrilled to welcome two guests today. This is one of those podcasts that if you happen to have the opportunity to watch it on YouTube, you probably will get some good visual aids going into this conversation. And if not, then our one of our guests especially will give us a little bit more of a visual and describe to us what you need to know. But our conversation today is with Diana Melnick and with Sara Klein. And I'm going to ask each of you to introduce yourself specifically, and then we'll introduce the topic. So, Diana, why don't you start? Tell us who you are.
Okay. Hi, everyone. I'm Diana Melnick. I'm in Toronto, Ontario, Canada, and I'm a registered psychotherapist and a certified sex therapist. I'm also a kalla teacher, and I also direct one of the MScPTs here in Toronto. One of the things that I do in my role as a sex therapist is I run a clinic together with Sara. And our clinic is actually a multidisciplinary clinic that focuses on helping folks who are struggling with sexual function issues.
Fantastic. Thank you for being here with us. Sara, let the people know who you are.
Hi, I'm Sara Klein. I'm really excited to be here. I'm a physical therapist who also practices in Toronto, Ontario, Canada, and I have a specialty in pelvic floor physical therapy, which means that I address anything related to bowel, bladder, or sexual health, and that includes working with Diana in a multidisciplinary fashion. I also work at the Hospital for Sick Children in the chronic pain program. So one of my passions is treating pain both in kids and adults.
Wow, chronic pain in terms of from the perspective of general physical therapy, not necessarily pelvic floor, particularly. Is that right?
That's right. It happens to be over the last little while, we've seen an uptick in referrals for pelvic issues, so pelvic pain. And also, as we'll discuss shortly, there are some things that look like hip pain or back pain, but actually have a pelvic floor component, and that's true in teens as well. And that's what we've been seeing, along with painful periods, pelvic floor dysfunction in
Oh,
the
so
pediatric
fascinating.
population.
So fascinating. Not a topic I would have thought we would be talking about. Very interesting and makes actually quite a bit of sense. I mean, I also think about just in the religious world and how very often our girls are marrying pretty young. They're many times actually just teenagers or just past teenage years. So it makes sense to me that there's to be some adolescent medicine component to, sexual health and sexual functioning that maybe potentially is not being really talked about. So we can always kind of put a pin on that one. Let's
It's
start off
funny
this
because I just want
conversation.
to say that like
Tell me.
I don't see teenagers in my practice unless they're like Hasidish married, 18 years old with a child, and then I will see
Right. Right, right, and we don't really we kinda like lump together anybody who got married young as no longer a teenager, and then that's actually kind of an interesting thing because I think when we talk about, some of the risk factors relating to perinatal mood disorders and adolescent pregnancies, there are actual physical components of, like, preterm labor, preterm birth, and, low gestational, low weight of the baby as well as low weight of the mom, and we give that all like, I think many of us imagine, oh, teenage moms, not in our community. And yet we have to acknowledge that many of our newly married couples who are having their firstborn within that first year are practically teenagers. And so I wonder how much of those risk factors are associated with that population. That being said, let's talk a bit about the pelvic floor in general. We've done a podcast with Rivka Sidorsky about pelvic pain and sexual pain specifically. And I think that I like this idea that we're going to back this up a bit and talk about function. And I heard you say you included bladder and bowel when talking about pelvic floor. And I think that that sometimes can be one of the most overlooked perspectives where I think there's such a lack of education around these issues in women in general, and they don't even know what they're dealing with. And it's not until they're in crisis and someone else knows what they're dealing with that they figure out, oh, I didn't even know that this was something that anyone else experienced. By example, I remember speaking with someone who we were at a bris, and she said to me, I could just tell, when you're a therapist, you can just tell, right? And you're like, all right, what's going on? And she said to me, everyone's just so busy telling me how thin I am and how skinny I am and I look so great. And she goes, I haven't eaten because every time I go to the bathroom, everything inside of me feels like it's falling into the toilet. So I'm just avoiding eating because I don't want to have to go to the bathroom. And, it was such a moment of what is everybody saying versus what everybody's not hearing. Got her into care very, very fast, thank God, and really helped her. And that was with a pelvic floor physical therapist. So that was actually a full on, it was a rectal prolapse that was utterly undiagnosed. And I just think about how long she would have suffered without having the response that she needed. So talk to me a little bit around, Sara, about what is this thing that we call the pelvic floor? And I want you to make sure that we include the fact that this is not just women, right? Men have a pelvic floor as well. We have a we have a pelvis. Men have a pelvis too. Talk to me about the pelvic floor.
Absolutely. Men and women, everyone has a pelvic floor. And we joke that even though we might talk about in the frum community or in certain communities, there might be a lack of awareness. Even when I went to physical therapy school 20 years ago, we talked about kind of the head to the waist and then kind of after the waist down. And then we knew the body inside it out, but we always missed that kind of really important region that actually ties everything together and has a lot of different functions. So I actually have a model, a prop here. This I carry around with me wherever I go. And sometimes my 18-year-old son finds it lying around and, it is what it is, but I'm going to kind of explain what it is and I'll give some words so for people who aren't watching have an idea. So this is the bony pelvis. This is how it sits on the body. So I have a pelvis here. So if you put your hands on your hips, you can feel kind of the top of the pelvis. If you put a hand under each bum cheek, we have a sit bone. We tend to slouch a little bit, but that kind of sit bone usually sits like this. And this is the base of the spine to the tailbone. And if we kind of flip this over, we know at the base of the bony pelvic is the pelvic floor. So it's like a sling of a hammock of tissues, muscles, fascia. It goes from front to back, from the pubic bone all the way to the tailbone, and from side to side, from sit bone to sit bone. It connects up to the abdominal muscles, hip muscles, and back muscles. If I kind of laid the pelvis down, if someone were lying down, we'd be able to kind of visualize what we see here. So just so everyone can see, this would be the clitoris, which is for female pleasure. This is the urethra, where we pee from. This is the vagina opening, and this is the anus. And it's 3 layers of muscles that actually work together. And even from that first layer, you could say how everything is intertwined. So it's really captures and encompasses a lot of different parts, including the bowel, bladder, and sexual function. If it's okay, I can just proceed and explain the 5 different functions of the pelvic floor. So we have 5 different functions that the pelvic floor has, and I'm going to hold this here so you can see. So first off is the sphincteric function. So we have sphincters or muscular control around our pee hole or urethra and around our anus. When we work well, we can open up, have a good pee, get everything out, open up the anus, get our bowels moving nice and smooth and easy, and then close up shop and not have any issues with leaking or incontinence, frequency, or urgency. Number 2 is sexual or penetrative function. So that would involve this area here. So then when there's good hydration of the tissue, so when the mucosal lining is kind of well hydrated and plump, good estrogenation and good hormonal makeup, when there's good lubrication or arousal, either lubrication from arousal or from external lubricant, when the muscles are able to fully relax and open, something can go inside without any issue. And that could be for sexual intercourse, it could be a tampon, a speculum, whatever it is. Number 3 is a sump pump function. So just like we had special blood vessels in our calf muscles when we walk that pumps fluid back up to the heart, same blood vessels occur here. So you need this kind of pumping mechanism to get everything kind of flowing. Number 4 is supportive. So our pelvic organs, our uterus, bladder, and rectum sit in here, and it's kind of like the strength of our muscles that keep them kind of holding up. And number 5, which is actually related to all of them, is that it's part of our core. So our core, we usually think is kind of like our abdominal muscles or 6-pack muscles, but actually it's kind of an inner unit or pressure system that is part of 4 different muscle groups that work together. So our breathing diaphragm on top that goes up and down as we breathe, the deeper abdominal muscles in the front, the pelvic floor in the bottom, and the deeper back muscles. And that means there's some sort of internal unit that's a pressure system that when it works well, when there's no kind of restrictions or vulnerabilities anywhere in that unit, as we breathe, those muscles relax and contract and give us inner stability and are able to work properly. And the reason I explain all that is to understand that these are muscles like any other muscles in the body. So my bicep, when I relax it, my arm straightens it. When I contract it or kind of, squeeze my arm together, it tightens. But I can't kind of walk around with it like this all day because it'll be tense and tight, might cause pain and dysfunction, but it also would not be strong because a tight muscle is also a weak muscle. And that in a nutshell kind of gives us a little bit of a framework of how the pelvic floor works.
Woo! I feel like I could break down every single piece of what you just said and be like, wait, let's review. Okay, so a tight muscle is actually a weak muscle. Can you just extrapolate on that? That's a fascinating idea that I think needs a little bit more explanation.
Yeah, so our muscles work in in certain, they're able to carry load in certain lengths. And if they're just kind of squeezed the whole time and really, really tight, they don't have good circulation, they don't have good nourishment of all the different tissues. And they also don't have strength because you need to be able to go through range of motion in order to kind of build the muscles in all those different lengths. So if we're sitting there holding our pelvic floors tight all day, whether it's because that's where we hold our tension, whether it's because we're carrying a pregnancy and working really hard, whether it's been because, God forbid, it's been a previous source of trauma and so it's very protective, or whether it's just because we don't know where those muscles are and therefore we don't know how to relax them, we can actually have pain and discomfort, but we can also have things like leaking. Imagine sneezing and your muscles are already so tight that they have nowhere to go, then you're not necessarily going to keep yourself continent, along with a slew of other things that can be dysfunction in the pelvic floor.
And that's one of my pet
Fascinating.
peeves, right? When
Yeah.
people assume that when they have urinary incontinence, all they need to do is Kegel. And that's just not right. Because if you're trying to Kegel an already tight muscle, like you're probably causing more damage.
Wow. Okay. So, what are the main things, Diana, as a therapist, as a sex therapist, especially a perinatal therapist, what are some of the key things that you find are showing up over the years that you've been doing this work that relate to pelvic floor dysfunction? Like, what are the main things that you're noticing that come into you as psychological, perhaps you could even say, that are actually rooted in a medical condition? Or vice versa, like that it's really, physical, but there's, what that psychological and physical relationship. What are you noticing?
Right. So one of the things that I see a lot is that people are not necessarily educated enough about what intimacy should or could look like in the postpartum period. And so what ends up happening is, when things are functioning properly as they should when you're postpartum, which means your pelvic floor needs a lot of time to heal. Even if you've never had stitches, even if you didn't tear, it's still there's some type of trauma that has happened to that pelvic floor region, to the muscles, to the tissues, whether it was a C-section, whether it was a vaginal delivery, it does not matter. That tissue needs time to heal. And that 6 week go ahead from the doctor is an arbitrary number. And maybe there's a small percentage of women for whom 6 weeks is a very good landmark at which they can resume intercourse. Great. That's not my experience. I think a lot of women need a lot longer than 6 weeks, right? Not to mention that, just in general, like estrogen, which is, when we look at sexual responsiveness, we have two hormones that are necessary to ensure proper sexual response, sexual arousal, sexual desire, and even just from a physiological perspective, as Sara was saying, to have like a comfortable and pleasurable penetrative experience. You need to have estrogen and you need to have testosterone, right? When a woman is pregnant, we talk about that second trimester as being the sweet spot. First trimester, you're vomiting all day. Last trimester, everything hurts and you just want the baby out. But that nice spot in the middle, if you're feeling well, a lot of women report that their sexual pleasure is at an all-time high. They're able to respond really well. And one of the reasons for that is because there's so much extra blood flow to the region and because their estrogen and testosterone are really, really high. Now, what happens when a woman gives birth? Not only does her estrogen and testosterone plummet and goes really, really low, but the prolactin that's being secreted to ensure breastfeeding and creation of breast milk says, sorry, estrogen and testosterone, you are not going to get higher. And so when you think about that, right, forget about any pain that someone might be feeling because they have scar tissue, granular tissue, or they might have, stitches that are healing, whatever. They just don't have the estrogen necessary to have adequate vaginal lubrication, but not just lubrication. We also talk about the plumpness and suppleness of the tissue in the vagina. So again, it can cause pain and it can cause discomfort. And then we talk about sort of when we think about sexual response, right? We do have that hormonal component, but then it's also where's my brain at, right? And so we understand that sex is a lot more than our genitals, right? Like, yes, there are cues in our genitals that, tell us that we're feeling aroused, but really it's about where's my head at? And if you're worrying about your baby waking up, you're worrying about how many poops they had that day, you're worrying about what it's like to transition to motherhood, or this is my seventh child, how am I managing, right? So there can be so many other things that are causing stress that it can be really difficult to just calm down and really compartmentalize and be able to get into the right mindset, into the right mood.
Okay, so I want to pause on the concept, the conversation relating to the sexual health piece, because I think actually I want to back it up a little bit more into the physical implications of pregnancy and birth on the pelvic floor, and then we'll move into the psychology, kind of the psychology and the physical component of pregnancy and postpartum. So maybe Sara, I want to hear from you a little bit more about what happens in the pelvic floor when there's a pregnancy. Obviously, there's the weight of the baby, right? That by definition, we can all kind of visualize that. That baby is sitting right there in the pelvis or pretty close to the pelvis, right? What are some of the things that go right? When things go right, what is the body doing? And what happens when things go wrong, either in pregnancy or postpartum?
Yeah, that's a great question. So we'll work through some of the different functions that we talked about previously and just say certain things that I tend to see. And remember, I'm also seeing the people who are coming with the issues, right? So,
Of
or
course, of
hopefully I
course.
am. Hopefully I am. And we have this concept of it's very common and very treatable. So thinking back to the person that you initially talked about, my heart goes out because I think there's so many people who kind of suffer in silence, and there's shame and guilt and just a non-awareness about what supports there are out there. So she was lucky that she found you. So what happens in pregnancy that can lead a person to come to seek some support, let's say from a physical perspective? So
Well,
the pelvic floor.
I want to back that up one step further. Normal, healthy physical experience of the pelvic floor in pregnancy. What is the pelvis doing? Because, like, for example, my understanding is that the pelvis is kind of spreading a little bit, not just holding the baby, but also muscularly spreading. Or, just kind of how the hormones are impacting the pelvic floor. Can you talk a little bit about that first?
Yeah. So everything stretches a little bit. We have hormones in our body to allow this a bit of expansion. We have the ability of connective tissue in the front. Our six-pack muscles are actually connected by connective tissue that is meant to stretch a little bit. You have the ability of very slight movements within the joint, but they allow the accommodation of a baby. We have the ability of the pelvic floor muscles to do that sump pump function, which is actually specifically important in pregnancy because we have more fluid running through our body in order to support baby. And so when that works well, that pumping system works really well. So the muscles relax and contract well so that the circulation can go. You don't get that pressure or heaviness. The core system that involves the diaphragm, the deeper abdominal muscles, the pelvic floor, and the back, they expand and contract. So you don't get, let's say, restrictions or vulnerabilities anywhere. So that core is working properly. And that expansion in the joints is not a major amount. So I'll talk about that in a second because there's a lot of misinformation on the internet and in the community about what that is. But you get everything. You might pee a little bit more frequently, which is within normal limits because you have something sitting on the bladder, but you don't go too frequently because you recognize that you only need to go when your bladder is full. And hopefully you don't have any issues with incontinence or anything like that. So when everything works well and beautifully, and a lot of the time it does, you're able to accommodate for this growing structure. You're able to kind of keep yourself moving and mobile because we want pregnant mamas moving and doing some sort of physical activity, even if it's just walking for 20 minutes a day. Everything kind of allows for that. When sometimes things go a little bit off is when something happens in that system that doesn't work well. So when the pelvic floor is working really, really hard and we're not learning how to relax and contract it with the core system, you can develop a little bit of extra tension that can cause some pain and discomfort in that region, which can impact sensual health, of course. But it could also create a situation where we get something called pregnancy-related pelvic girdle pain. And what that means is really it's a location. It just means pain anywhere in this region in any of the joints. And really it's, pain is actually an output of the brain, which I don't know if it's a concept that's a little bit more novel for people to understand that really our brain sends us some danger message in the form of pain when it wants to alert us of something. In pregnancy, that danger system is a little bit more on high alert because we're kind of looking and making sure all our being is to make sure that our pregnancy stays and is healthy. And so every sensation that we get from our body potentially can have the dial turned up on it. And because as where baby is growing and everything is happening so rapidly, sometimes some of that information is processed as danger, especially if we have kind of like a higher level of stress hormone, especially if we have some preceding anxiety or depression or mood issues, especially if there's some fear or catastrophization. That's going to turn the dial out on that knob. And that can create a situation where you get a lot of discomfort in this region. The misinformation I was talking about is this idea that, we have something called pubic dysfunction or dysfunction in the pelvic region where things are splitting. And that's what happens actually if you Google pubic symphysis pain, which is a common location of pelvic pregnancy-related girdle pain, where someone who's already a bit vulnerable, who already is feeling a lot of discomfort with movement, reads on the internet that her pubic bone is splitting apart, and that's what's happening. That is not true. That is completely not true. That is fear mongering. And that's going to dial up the fear messages and the danger messages that are going to be an output from the brain and actually create a situation where there's more fear of movement, more tight muscles, less, less kind of natural lubrication of the joints and create actually a lot of, I've seen women who unfortunately are bedridden because they can't move because there's so much pain. This is the most stable joint in your body. This area it can have aches and pains, no doubt, just from things happening rapidly and changing rapidly, but it's not going to split. There's no reason for it to split. And in fact, a lot of that sensitivity is sometimes just some of that messaging from the brain related to fear sensitivity. It's like an amplified system where there's sensitivity to every single sensation in the body. So I see a lot of women with this type of pain. And really the first step is just education about it. And even sometimes that reduces someone's discomfort because all of a sudden they feel safer in their movements and we just find different ways for them to move. Constipation is a huge issue in pregnancy. And in fact, prolapse, one of the leading factors of prolapse is pressure on the pelvic floor, including extreme constipation and straining on the pelvic floor. And we say that constipation is any excessive straining. So people could have easy form bowel movements. Sorry, I hope that that's not TMI. We talk about pee and poo all day in my house and in my clinic, but nice form bowel movements still require that you don't strain. And because we're moving differently, eating differently, our sleep is different, our stress is different, like digestion and all that stuff starts from the second you think about eating food. So because of all those changes in pregnancy, people can end up with a lot of issues with straining and constipation. So we would address that and look at all the different contributing factors why someone might have straining and make sure that we get on top of that. So that's another important thing to address just through a multimodal approach. And then of course, issues related to leaking and incontinence, really looking at that whole system, looking at someone's, how they're relaxing and checking the pelvic floor, excuse me, but also their habits, like how frequently are they going, or are they responding to every cue to go when really they don't have a full bladder? Are they power pushing their pee out and causing more dysfunction there as opposed to just kind of letting it go using their breath and some other techniques? So there's kind of like the behaviors and the habits, and then also, the strength of the muscles and that whole core system.
So fascinating. I want to clarify one question that I have, because I definitely have heard this term of, that the pelvis split. Now, typically I hear it postpartum, meaning like that it was a birth injury. Are you saying that that's a misnomer?
So in terms of there could be things that happen in the birth that are beyond what this pregnancy-related pelvic girdle pain is, but the
Okay.
typical pregnancy-related pelvic girdle pain that someone has with those,
Okay.
extremely significantly impacted pelvic during pregnancy actually can last a year postpartum. So that would actually be in the same kind of realm. And I see lots of women like that. Something that happens specifically during birth would be a little bit different.
Be different. Okay. I just wanted to clarify that, because I do know that there are women that have like a pelvic floor, like have a pelvis fracture from a severe, like we'll consider like from a severe birth injury. But really interesting how the psychological component and the relationship to our body. Diana, what do you want to talk about on this issue? Because this is so big when we begin to understand the psychology in relation to the body experience.
Yeah, and this is literally why Sara and I work together, right? And so I know you did a whole episode on pelvic pain, so I'm not going to get too deeply into that, but this is it, right? So many folks who come in with some type of pelvic pain issue, they'll sometimes come to me, or they'll go just to Sara, and we each do our own individual assessment or evaluation. And more often than not, we are now referring to each other. And not because we want to make money, but because we understand that the way to help people overcome whatever sexual pain or other type of issue they're experiencing is to do 50% mind and 50% body, because it is all interconnected.
Yeah. And I think about that from like the anxiety perspective. If we were looking at a clients or patients who are dealing with a high anxiety, you can imagine how a little bit of pain becomes a larger amount of pain, becomes an obsessive amount of pain, becomes like anxiety all the time around what my body is feeling. Are you noticing that in the women that you serve? That kind of like hyper arousal, hyper awareness of pelvic floor and everything that goes into that pelvic floor?
Yeah, absolutely. And of course, like we talk about, again, it's so difficult for one of us to just sit here and talk in some ways because you can see how interconnected it is. And when somebody is very anxious and they're holding all the stress in their pelvis, right? It can be really difficult to relax and even to, again, like we talk about this idea of compartmentalizing during intimacy with a partner, right? Like if nobody compartmentalized, no one would have pleasurable intimacy time, right? So it's such an important factor, but folks who are extra stressed or extra vigilant or extra anything, right? They are not able to compartmentalize. They're not able to get lost in the moment and let the pleasure of intimacy overtake them, right? They're not able to be mindful and really embodied in the experience, which is like that's what we need in order to feel pleasure with a partner.
And I imagine even if it's not about sexual pleasure and it's purely about sexual functioning or physical functioning, part of that idea of like just relax is not enough, right? There's so much more that goes into the
I'm just even
relaxation.
gonna jump in and think, what do you mean it's not about pleasure? Because we're unless somebody is
No, no, I
specifically
was just
on a
saying, I was
journey
saying,
to conceive,
no, no, no,
unless
no,
you're
no. Let
trying
me
to
clarify that. No, no, no. I'm saying not just about about the sexual experience. I'm addressing physical functioning, right? So the
yeah,
physical functioning of like, I'm having a hard time going to the bathroom, right? Or I'm having a hard time getting that poop out, right? Or my pelvic floor feels weak and I'm not able to, react in the way that like, or I'm running to the bathroom and I'm losing either my bowels or urine. That's what I was meaning and saying not about pleasure. Um, don't get me in trouble here.
okay.
This idea of like that just telling somebody you have to just relax and allow your bowels to just exit your body is not enough. It's not addressing the really core issue that's happening here. Sarah, what are some of the things that you see, or what's some of the techniques that you're involved in with Diana, I guess you could say, in terms of addressing it's more than just relax. And I am looking more in this moment in conversation about physical function, like relating to going to the bathroom or maintaining your bowels and things like that, especially because I feel like that's such a big thing after women give birth and in pregnancy as well as postpartum.
Yeah, yeah. And it all comes back, as Diana was saying, to this biopsychosocial model that we're always looking at biological factors, physical factors, psychological factors, and kind of interpersonal or intrapersonal sociological factors. And I'm going to focus a bit more on the bio, but certainly when I give out my intake forms, they're evaluating for the psychosocial. So I'm getting a sense, is there catastrophization? Is there a history of anxiety and depression? Is there a lack of understanding of what that part of the body does, right? Because that's also something that's in the brain. And so really, after I do that evaluation, I would say, Diane, I'm going to argue with you. I don't think it's 50-50. I think it's kind of like a spectrum with the BPS. And, sometimes I see people and it's way more on the bio, right? Like this is someone who's, doesn't have any mood issues, doesn't have any relationship issues. Really, it's just like the scar tissue needs to be massaged and we need to relax those muscles in with the core system and get some strengthening and we're good. And then sometimes it's the more psychosocial that my entire exam is completely normal. And yet for interpenetrative intercourse, they're having tons of discomfort. And so what does that mean, right? It's something about the body's protective response related to that event, because pain is contextual, right? All of our pain is in the brain and it's going to be the context as well. So after, when we do that evaluation and when I do that evaluation, and we're always referring back and forth, like you said, I wouldn't necessarily treat simultaneously with Diana, but I'm always focusing and cognizant of the impact of the thoughts and feelings and emotions related to what we're doing. And so it's so amazing that we were created with the diaphragm, our breathing muscle, related to the structure of the pelvic floor and the ability of it to relax and contract, because breath work can be so essential for calming down the body. So almost always I'm starting with how to connect to your breath, right? And I have the ability of putting my hands, right? As a physical therapist, I'm putting my hands on their ribs, I'm putting my hands on their chest, I'm able to put my hands on their pelvic floor if that's indicated, or even internally, and really kind of getting them to just become aware of their body and how to relax their body. And it's not just about relaxing, it's about kind of teaching your body not to be in protective mode, teaching your body to elicit what's called the parasympathetic response, which is helpful for mood, but also also for pain, because we're kind of going from that fight or flight where our body is tensing in anticipation of something or just all the time, and getting into rest and digest, where we can actually access and relax those muscles so that we can then start to adjust their functioning properly. And then we're always relaying back and forth, like, how do we use those techniques to support, let's say, exposure to dilators, which can help maybe expose them to sensations internally so that they can, be able to have pain-free intercourse eventually, or maybe incorporating a partner in some of those things that we're doing. And that would be, I don't always see partners, so that might be something that I relate to Diana. So we're really kind of always juggling back and forth to support the couple or the patient.
Can I say
Okay,
something?
so
Because I think, well, I want to say one thing before you jump in, which is, what Sara just described and the way that and this is, she's amazing. And in general,
clearly.
yeah, she is. But, Canadian healthcare is pretty awful. But one little tiny area where I feel like we can actually pat ourselves on the back is in this realm of women's sexual health and pelvic function. So what Sara described, that, the way that she works as a pelvic PT with this mind-body approach, with the breathing, with the down training, not all pelvic PTs work that way. And this is a huge difference I see between Canada and America, where if you can take the same condition and send to someone like Sara, and you can send to a pelvic PT who's very well trained in the States, and they've never even heard of diaphragmatic breathing. They've never even heard of this idea of down training and getting the body to relax and incorporating the mind-body approach, right? So they might use more medicines or definitely physical techniques, which is great, and all of that is important, but sometimes that can be missing.
Fascinating. Absolutely fascinating. Okay, so let's talk a bit about the postpartum woman and now resumption of sexual function. So let's say, things look pretty okay throughout the pregnancy. We haven't had any major issues. We don't have an identified major issue. She gets the permission to go ahead at 6 weeks or more. I think that, I think we really have to acknowledge kind of like the injury to the area, right? That there is an injury to the pelvic floor of just by the fact that you gave birth and pushed out a 7-pound baby or more, 9-pound baby, right? So there's definitely has to be some recovery that's necessary. I think both of you probably would agree 6 weeks is probably on the very, very low end of recovery, of the recovery experience. What's happening physically as the body is attempting to recover? What is actually happening from a muscular perspective, as well as from a tendon, et cetera, perspective? What's happening in those weeks postpartum that's important for us to understand about our bodies from a physical perspective, Sara?
Yeah, so 6 weeks is kind of like a subacute tissue healing mark, right? So, or like the acute stages are gone. And so 6 weeks is like if you fractured a bone or have a sprain or you have some sort of surgery, like that's when things are meant to be healed, so to speak. And very well, like usually people are discharged at that time. So the tissues themselves usually are healed. The stitches are healed and hopefully dissolved. The C-section scar is healed, right? Things are healed. But it doesn't mean that they're not sensitive or tight or haven't moved in a really long time. The impact of hormones is huge. So as Diana was mentioning, if someone's breastfeeding, for sure, the amount of estrogen is almost like a postmenopausal woman. And even if they're not, for the first few months postpartum, estrogen is really low, and estrogen is responsible for the plumpness and kind of hydration of the mucosal lining. So, so we can imagine, as well as muscular integrity. So we know that that's really, really low. So at the time when you need it the most, at the time when you need the most amount of sleep and, healing, is probably the time where you get the least of that. And you're kind of the expectations around kind of women also. We could speak for a very long time. So, in general, what I tend to see is women who are coming in with pelvic floors that just haven't moved, that maybe had stitches and they're kind of very tight, that maybe have some scar tissue because they weren't massaged postpartum, even though you can start massage sometimes at 4 to 6 weeks, that have just worked so hard and are in that kind of state where there's a bit more tension, that maybe if there's lack of sleep and maybe some fear, or maybe if someone's tried to have sex, they're much more in protective mode, especially if it hasn't gone well because they didn't use enough lubricant or what they thought. Your body's a bit different. Like tissues are healing, the body's getting back to normal, but it's different. Like what you liked before in terms of sexual pleasure is different. What the tolerance of touch is different. So everything's just different. You weren't the same as you were, but it doesn't mean that you can't get back to a new normal. The abdominal wall, like people are also concerned about their aesthetic appearance, like things, get stretched out. And again, our body is resilient and it was made that way, but sometimes people end up with what's called a diastasis recti, where the connective tissue that is meant to stretch between the six-pack muscles or rectus abdominis remains more stretched. There's a lot that goes into that, but maybe people look different, and so they maybe don't feel as appealing as they were. And so there's lots of things
Did
that
you
are
say maybe?
yeah, potentially maybe. So there's lots of different things that are going on. So at the 6-week checkup, we're kind of checking in. I usually, if I do a labor preparation session prior, I usually say 6 weeks. It's just a marker. It's just a date. Hopefully everything's healed, and that's amazing, and that will be great. And if you go to the mikveh, amazing. But please first come to me before trying, going back to running or exercise or sexual function or sexual intimacy, just because we can check in and make sure that things are really, and sometimes women do really well and need just a little bit of get those tissues moving again, look at that whole core system, learn how to expect and how get back to the stretches and things that they want to be doing, and the gentle strengthening. Sometimes they need a little bit more intervention, and I would say the benefits of estrogen or a moisturizer potentially, along with some of the physical strategies, can be super helpful.
And I just have to mark here the fact that you are really speaking from a Canadian perspective, because my understanding is it's covered in Canada, right? It's insurance it's not covered in Canada.
So I'll tell you what yeah. So if someone has extended health benefits, which not everyone does, and that usually comes with some sort of job where you're not self-employed, where you get good benefits, usually you have a bucket. I'm going to not speak for everyone, but maybe a few $100s, $300 to $500, maybe if you're lucky more.
Okay.
And pelvic physical therapy is on the higher end. So a woman in general in a year might only have access to 4 or 5 sessions that are paid by insurance. And I just spoke about maybe coming in for a check-in prenatally, then some labor prep, and then postpartum, and then recovery. So you're really going through those quickly.
Okay.
And so it isn't accessible, and that's a big problem. What I thought you were going to mention, which I also think is a big difference, is here you can get a little bit of you can get maternity leave, which isn't a lot of money, but you actually can take time and you secure a job for a year. In the States, some of my friends had to go back at 3 or 6 weeks, and then it's like a completely it's just mind-boggling to be able. And then on top of all that stuff that I said before in terms of the expectations and getting back, you're working and pumping and running yourself,
all
who
that,
knows? And
all that.
that
Right. My understanding is in Europe, there is some level of PT coverage, of pelvic floor coverage as as an opportunity in Europe. And unfortunately, the United States does not. And frankly, the amount of women that actually take insurance, the amount of PT specialists that take insurance in the United States is very low. I live in Philly. I could give you the name of one practice locally that takes insurance. And that's a really chronic issue. I want to make sure I have time to get to Diana. Diana, let's talk a bit now about resuming sexual functioning. Yes, with pleasure. Postpartum, let's say we get the go ahead. We have no reason to believe there's going to be a problem. And then kind of talk to me a little bit about that reintroduction of sexual functioning for a woman that is postpartum. What are the things you want us to understand?
So, I think everybody has to understand that this is going to be different. Okay. Do not assume that things are going to go back to the way they were either when you were pregnant or before you became pregnant. And that's something that I think a lot of folks don't really internalize, right? Like you go on Facebook and you read in these mom groups, like, what's wrong with me? I had a baby 8 weeks ago and I have no libido. I have no desire, or I haven't been able to orgasm since my baby was born 3 months ago, right? And so again, there's this lack of awareness that in the immediate postpartum, so definitely up to about 4 months. I'm not saying that nobody will orgasm. I'm not saying nobody will feel pleasure or be able to resume sexual activities as usual, but that's a minority of people, right? Usually until I kind of give these goalposts. I say 4 months is a little bit of a change. 4 months postpartum, 6 months postpartum, when you're introducing solids, when baby starts maybe sleeping a little bit longer, right? That could be a marker, right? And then really up to a year. I say give yourselves a year, a full year to recover postpartum, to get things back to how they were beforehand, if possible. And then you add on top of that, especially in the Orthodox community, by a year postpartum, you're usually starting to get pregnant again. So you never even get normal between breastfeeding and pregnancy, right? Which is really interesting. But coming back to this idea, what is the new normal, right? So first of all, physiologically, right? Things that people may have enjoyed before may not work anymore. So we talk about breastfeeding and milk leaking and, certain parts of the body over there where people used to really enjoy that. But now, you know what? It's a different ball game. Like they don't want to incorporate their breasts into their sexual function, right? Talking about the ability to get aroused and to lubricate, right? So again, for so many women, they check in with their bodies about how aroused they're feeling based on the amount of lubrication they're secreting, right? And just again, postpartum, you may not be able to just physiologically secrete as much lubrication, right? Not to mention the whole, again, like as I was saying before, this idea that there's a lot more going on in our brains when you're a new mommy, right? And it doesn't matter if it's your first child or your seventh child, right? You're still a new mommy and there's still a new human you're taking care of. You are going to be sleep deprived for the most part, right? You are going to be having the extra added stress of worrying about another human being on top of everything else. And yes, Sara said that in Canada, we are very fortunate that you can take 12 months, 18 months mat leave, right? But I can't even imagine in the States having to go back to work when your baby is 6 weeks old. Like, to me, it doesn't even make sense. Like, I would not even understand where in your brain and body there would be room to think about intimacy and pleasure and self-care, right? It's almost impossible. So we really need to be able to carve out space for ourselves to enjoy intimacy and to get our body to feel relaxed and to feel desire and arousal. And it's a very tall order when you're in postpartum.
Yeah, I think about that as like, the thing that keeps coming up for me here is also the conversation about this is a partnered experience typically, right? We're talking about this with the husband. And what are we discussing? Like, what are the messages that really would be helpful? Perhaps you could say it in a positive form. What are the helpful messages that husbands can better understand about what's actually happening for a woman in that experience? I guess more like, I think I'm thinking about it from a communication perspective, that idea of like, I would love to, but I'm not available, or I would like to, but I can't. Or I guess just thinking about like, how do you navigate some of that couples work, Diana? Like in terms of working with someone who is absolutely not ready for every reason you just listed, but there is a lot of pressure. And I think that's one of the things that we're hearing from many young women, unfortunately, is this idea of like, but I have to, or but I should, or I should just do it. And not even forget the fact that they're not even addressing the pleasure versus the pain component of it, but it's the internal family pressure of this is my responsibility, obligation, maybe even a halachic obligation, religious law obligation. What are some of the ways that you help couples navigate that disparity?
Right. So first and foremost, and I've worked with hundreds of couples. I would say that the majority of husbands report that the best and most pleasurable sexual experiences they have are the ones in which their partners are experiencing pleasure. And I know that, yes, like when you've been in a dry spell for weeks and weeks, you'll take anything you can get, even if it's not the most pleasurable experience for you or your partner. And I get that. But at the same time, keeping in mind that I think that most healthy relationships, right? One of the ways that you experience pleasure in a very heightened way is when there is both giving and receiving pleasure, right? So helping a partner, especially a male partner, understand that, like, okay, guys, like, this is the time when we need to slow down. Maybe focus on quality versus quantity. Can you, have kind of take the pressure off for this to be the most passionate, fireworks, explosive experiences of life and just take it down a notch and understand that, like, for the next few weeks, for the next few months, we're going to do things a little bit differently. And that's okay. And again, helping the couple get out of what we call the initiator rejector cycle, right? So the initiator, he's constantly begging for sex. She's constantly rejecting him, or once in a while, she'll say, okay, fine, and it's the pity sex and she does not enjoy it and she just counts down the seconds in her head until it's over so she doesn't have to do this again. But again, he doesn't feel fulfilled. She feels terrible about herself, right? And so what ends up happening is, because he's so not fulfilled, it makes him just want more, because he's like, wait a minute, maybe if we do this again, I'll feel better. But the same thing is going to happen, and they continue going through that cycle. So I tell couples to really take a step back, look at your schedule. People hate when I say this, but I don't care. I will stand by it. You take a look at your schedule and you see, when is the best chance of this happening in a way that we can experience pleasure. So it may not be at 11 o'clock at night. It may have to be earlier in the day. Or it might have to look like, husband comes home, takes care of baby, so wife can take a little nap so that she has some more energy to be present later on that evening, right? So it's really about communicating about it and being really honest about what is realistic in these few weeks, in these few months, and then trying to make it happen in a way that which is as conducive as possible to the relationship.
And then I guess the question that comes to me at this point is this idea of what happens when she's really struggling with sexual pain, and that pain pain becomes a primary actually emotion, or experience of like, I don't want to do this because this hurts. And she maybe hopefully has already sought access to a physical therapist and they're working through some of the issues. And maybe there's a real physical dysfunction that has developed postpartum, so now we're compounding it with this feeling of like, I feel so badly, but I'm also in pain and I can't do this right now. What are some of the things that like you're doing to help couples navigate when sex is actually quite possibly off the table for right now?
Yeah. So almost all of my sexual pain couples are not having intercourse, but they are having sex and they are having intimacy and they're having pleasure if possible. So what does that mean? It means that we take anything that is causing the pain off the table and instead we focus all the intimate experiences on whatever brings pleasure, closeness, and intimacy into the relationship. Right. And again, it's going to look a little bit different because maybe the thing you were always used to doing, penetration or intercourse, is off the table, but there are so many, and you see how many books I have behind me? There are so many things you can be doing as a couple to bring pleasure and closeness in the relationship that don't involve causing pain to one of the partners.
And then I think and then we have to also always give consideration to like the halachic ramifications of these issues. And like
So we speak,
I
we
think
speak
this
to
is
the Rav. You speak to
right.
the
I was just saying,
Rav.
like, this is one
Yeah,
of those times that we're like, rabbinic consideration and collaboration is very valuable, right? What is
absolutely.
And Sarah, what are the things that you're thinking about when working with somebody through sexual pain and kind of the feeling that I'm wondering if you feel as a provider, like a little bit of this pressure, like this has to hurry up because there's this internal or home pressure of resuming the sexual experience. What are some of the things that come up for you?
Yeah, I guess I say this is a marathon and not a sprint, and slow and steady wins the race. And that really, if we're going to push it and we're going to reintroduce something that's aggravating, I had someone in my clinic today. My recommendation clinically was not to have sex. She's having 10 out of 10 pain, but she feels that pressure and she's just going to keep on doing it. And while we're trying to reduce that protective response, while we're trying to heal the tissues and allow the body to be able to tolerate touch that's non-threatening, if you keep on putting that aggressor in, it potentially could negate some of the work that we're doing. And I really think we get faster when we move slowly. We get to where we want to go faster. And I think that both partners, ultimately, if we do a good job educating, really would support that because they want to get to ultimately a fulfilled sexual, life together.
Sure.
And so I'm meeting the client where they're at. I'm encouraging them to be as consistent as they can with all the information that I'm giving in their follow-up program because if we're rushing towards something and not necessarily hitting all the markers or doing all the different components of the home programming and things like that, it's going to also be a challenge. So I'm trying to be encouraging and motivating, but a little bit tough. And I try not to let those types of timelines get in my way because I think they just cause too much pressure and they're not
It's
necessarily
true.
helpful.
Can I
True.
say one thing about the Rav?
Yeah.
Because I think that in today's day and age, thank goodness we have so much awareness about how detrimental painful intercourse is to couples and relationships that the majority of, again, like educated Rabbanim understand this. And anybody who's going to their Rav, hopefully they are not telling them to continue harming their wife. And if somebody does go to a Rav and they see, okay, obviously my Rav has never dealt with this type of a situation because they're giving me advice that doesn't feel right. Find a bit like any big, well-known posek has tremendous experience with this and would be able to guide a couple accordingly.
Excellent. So let's end up today with I'll ask each of you for two misconceptions that you would like to kind of blow out of the water. Two things that are big misconceptions about the work that you do. Sarah, I'll let you start.
And I was going to say, Dana, you take it
I'm
away.
like trying to
Um,
think.
yeah. Yeah, I really want people to understand that all these symptoms that I talked about, they're not to elicit fear. Like people come in, they use heavy language. My body's gonna be torn apart. I'm gonna be, my organs aren't gonna fall out. Your body is resilient. It is resilient and it is made to function like this if that's how you choose to function, like to be pregnant and have healthy pregnancies. But if you do develop any of the symptoms, don't feel shame. It's common and it's treatable. You just need to seek the right help. And then in terms of pain, going on and on with pain, pregnancy-related pelvic girdle pain, pain with intimacy, sexual function, it's not that repeatedly exposing yourself. Oh, if I just do it one more time, if I just, the hole gets bigger, if everything, if I get pregnant and then have a baby, everything will get healed because I'll stretch that hole that was previously tight. It's usually not true. When we sensitize our tissues, when we create more painful experiences, especially in such an intimate area, our brain develops this protective response where it actually tightens and sends out the stress hormone, and all of a sudden you're protecting even in anticipation of that. And so you can develop that pain pattern even from kissing or hugging. So those would be my two things, and
Big,
there's lots of
fabulous,
good treatments.
fantastic. Diana, how about you? Two
Okay, so
misconceptions.
I'll try. Well, I'll start with one. I wish we can get rid of the word libido. Okay.
Okay.
Everyone imagines that there's magical force within us, like hunger or exhaustion. So you have libido, this desire. And really, it's such an outdated concept. What we understand about sexual responsiveness, sexual arousal, and desire is that it depends on so many things, the biopsychosocial, right? It depends on this beautiful holistic interplay between our biology, our psychology, our sociocultural context, and our interpersonal relationship. And not to mention that everything that's going on in the world, in our lives, our work, all at once, right? So who cares about libido? Who cares about this magical, mystical force? All we want to care about is what is the reality on the ground for me? Can my partner and I carve out a time and place and space to be intimate and connective and affectionate and allow pleasure to enter our relationship, right? That's what's important. And sometimes it'll be higher and sometimes it'll be a little bit less. But the whole purpose is really about how connected can we feel in these moments and not to worry so much about libido.
The libido. Amazing. Do you want to give us another one or you want to leave it at that?
I mean, I think that's a good one. And also, I
I
guess
think that's a great one.
that people shouldn't compare themselves. This is another thing that I get asked. Well, what are most people doing? How often are most people having sex per week? Is this normal? Is this normal? Okay, relax, everybody, right? Normal is what works for a couple. If this feels right for your relationship, fantastic. Let it be. If something feels off about this, then let's work on it. Don't worry so much about what's normal.
Love it. I love it. Thank you so much to both of you for sharing some time with me today. This was jam-packed with education. I think we'll probably have more questions afterwards that will need to be answered, but this is a really wonderful way to start. And thank you so much for your time.
Thanks so much
Awesome.
for
Thank
having
you.
us.
Thanks for having us.